Good afternoon. Bienvenue ici à Genève, la siège des droits humains, the Center of Human Rights, the WHO and to the WHA. My name is Andrea Lucard. I am here representing Women in Global Health Switzerland. I am a transplant to Switzerland from the United States, from England, and now I am Swiss, which represents many of the kinds of things, many of the international parts of this city and of this country that make us very special. Women in Global Health, Women in Global Health in general will be introduced largely by one of our distinguished guests who's going to be coming next. But I do want to talk just for a moment about Women in Global Health Switzerland, who is represented here by our matriarch, Carmen, who has been one of the really major driving forces for our organization. Women in Global Health Switzerland began actually with work that was done by a couple of our colleagues a number of years ago, maybe already 4 or 5 years ago. And just this year, we have now established ourselves an association. So we recommend anyone who's interested and who's here from Switzerland we'd love to have you join us. We'd love to have you be part of the work that we're doing, which is to amplify the work that's happening in women and global health globally, to make sure that women's leadership is recognized and understood and put front and center in health, since we are women, largely the health workforce globally. It's also to welcome chapters and people from all over the world. Those are brothers and sisters, our sisters and brothers, our siblings, who are coming in and are engaged in this kind of work, to come to the home of Geneva and around in Switzerland, to be welcomed and to be able to work in the center of peace and humanitarianism. And then we also have some other special areas of expertise because we're Swiss. We are very heavily in the pharmaceutical industry in Switzerland, so therefore we're quite interested in working in pharmaceuticals. We're absolutely working in mentoring and other things. So there is an opportunity later this week to join us for a meet and greet on Thursday, and I'm looking at Anna, and it's at 4 o'clock and 5 o'clock on Thursday. Okay, so there'll be some information there. And for you to join us. In the meantime, I welcome you to this very interesting panel. People I'm just meeting now and some old friends, and I'm looking forward to it as well. In the meantime, then, we're going to have a very interactive session, despite the fact that they're sitting behind mics and sitting behind the table. This is a small group with a real opportunity to be able to share and to ask questions. We will have an introduction from Sarah Kosovic, who will come up in just a moment. She is on the chapter steering committee of Global, representing Women in Global Health Global. She's a researcher, and she's also in the Women in Global Health of Sweden. She is a researcher at Stockholm University, and she just given me the name for Karolinska Institute, as it turns out. She also gave me an interesting piece of cultural knowledge today, which is that in Sweden, you never make this kind of introduction without showing people where the emergency exits are. We don't do that in Switzerland, but it's a good idea, so we will take that from Sweden if that's okay. And please welcome Sarah.
Thank you so much for the warm welcome. My name is Sarah Czauszewicz. I come from Women in Global Health Sweden, as you've heard, and I'm really thrilled to be here today to experience firsthand the hospitality. I haven't still had chocolate yet, but I'm hopeful to get some today. But I'm still very hyped with adrenaline and serotonin, and happy to be here today. Ladies and gentlemen, colleagues, friends, it is my job also as an academic to do some research about today's subject, and that is something that I will also give to you in some of the points and observations that I will lay out. But as academics, we also have the academic freedom to speak, our thoughts and to give some personal reflection of the things that are happening worldwide, not just also in written form, but also in oral form to different audiences like this one. I have 3 points. And as I said, the first 2 are a little bit about data. And that is that first one is that gender equity and universal health coverage must be safeguarded and not assumed. And that is something that I think we all know, we all read, and that is why we're here today. That is why we have the Women in Global Health movement. That is why we have UHC 2030. What is happening nowadays, and these are the many discussions that we hear, not just in this room, but overall in Geneva and then globally, is that there is a rollback of human rights. There is a rollback when it comes to democracy, and that first and foremost means rollback in gender rights as well. So we fought very hard for getting our themes there, and now is not the time to give up. And when it comes to UHC 2030, we still unfortunately have to fight hard to keep gender there, not just as some decoration or as a clause, but to have it institutionalized, to have it in all the health system building blocks, so that it is in financing, it is in health workforce, it is in governance, it is in data as well. We sit in Geneva, we sit in a high-income country here today. We come also from high-income country, many of us, but we must not forget that women are very much forgotten in many of the health system building blocks, data. So it's a visibility of those that are out there. The second thing is that gender and human rights cannot be addressed in a vacuum. This is a broader struggle for human rights, and this is something that we also know very well. And we hear about austerity pressures, we hear about, money being gone. But this morning I was listening to a panel. We speak a lot about money. We speak a lot about, return on investment. You invest $1 here, you get, however many more dollars there. And we think that that speaks to politicians. That is what I've heard in the panel this morning. These are not my thoughts, but I completely agree with that. And politicians seems to, kind of bite that, but not really. They do care about resources. Of course, it comes to a certain point, but then there are different political interests that prevail. And in those political interests, there are no women, unfortunately. So as I said, there's still a fight that we need to keep on. Yes, less resources, but someone needs to hold the front line. And my third point is, since I come from Sweden and we have a word, it's called medmänniska. So that means literally human fellowship. It means, closeness. It means sharing what you have because you are from the same species, right? And my personal thoughts, and the third point is, today we have civil society representatives. And when you speak about civil society, it's not just, a structure with a governance and you have an accountant or someone. It is, people coming together for a cause, or something that they need to give a voice to, something that they feel like needs to be corrected, something that needs to be put out there so that everyone is better off, right? Rarely have I seen associations of patients or civil society organizations coming and being like, I'm here for the money. It's actually, some kind of health issue that brings them together, and they're like, tell me what to do. How do we bring this forward? We're stronger together. This is like the medmänniska. But what we often forget is that even though, there's austerity, the life did not end when international aid ended. Labors going on, conflicts and bullets flying through people's bodies. And still we have frontline workers that do not give up. And we forget those people. And these are the people that are not, they're not guided by global declaration. These are women. 75%, as we know, of the healthcare workforce is women. And in many of these zones, low income, conflict, climate change, whatever, they're holding the front. It's not just the frontline workers is the last line of defense. And then we need to ask ourselves, who is telling their stories? What we've seen, rarely the governments. It's actually these people. I'm happy that you will hear the stories of what they do when it comes to gender equality and universal health coverage, and that they will tell you what happens on the ground and how they're contributing to our fight to institutionalize gender and move it on in Universal Health Coverage 2030. Thank you.
Thank you, Sarah. Actually, from now on, I'm not going to introduce the fire exits. I'm going to introduce the fellowship. I'm going to have to learn the word, however. So it's my great pleasure to introduce my colleague and my friend, Carmen Sant, who's a researcher at Swiss Tropical Institute. Her CV is as long as my arm and actually longer than the number of years that she's lived, I think. But in particular, she has a real expertise in gender-based violence and universal health coverage, and is often abroad working really, again, on the front lines, particularly in gender-based violence. So, Carmen, without any more than that, I would like to you take over the panel.
Thanks so much. Yes, sorry. Hi, everyone. Thank you so much, Andrea and Sarah, for setting the scene. I think this was a wonderful start to what will be, I hope, a very enriching and interactive session. So as Andrea mentioned, I'm here representing Women in Global Health Switzerland, and I'm accompanied by wonderful panelists, some Women in Global Health fellows from other chapters, as well as Anja Maria and Elvis that represent other types of institutions. I will not be introducing them. They will be introducing themselves. Before then we go into kind of who is who, let me just kind of take it from where Sarah left it. And I think the word Nisha, I don't know if probably mispronounced, but as Andrea was mentioning, I think that's really our goal for today, to build alliances, to get to exchange with you, to join forces and see how can we move together this agenda so that we don't work in isolation in whatever country, community, or global type of meeting room we find ourselves in, but rather as a joint movement. And I think for me, that's really the beauty of the Women in Global Health movement, that we are very diverse, we are many voices, but we have some shared values and that we, push for them. As Women in Global Health Switzerland, as Andrea was pointing out, and some of you may have heard already, universal health coverage is kind of one of our key backbones of what we want to do as a chapter. And already in 2023, we hosted kind of a more political type of discussion in terms of how do we bring, back then it was the high-level meeting had occurred in September of 2023. There had been some commitments on universal health coverage. And there were also at the global level some commitments on gender. However, Anna Soja, who is sitting there in the back, she did an analysis also on how did those commitments translate into commitments at the regions. And we realized that when we looked at those regional commitments, a lot of the gender, human rights, equity wording, well, maybe equity not so much, but the gender had been washed out and was less present. So we came together with some policymakers as well as international organizations to discuss how do we ensure that these commitments also translate into action. A lot of our work is also about how do policies translate into actions? Because yes, we need comprehensive, we need progressive, we need policies that push for gender and human rights. But then if that doesn't translate into the frontline workforce, into the community, it's a nice paper that can be, put in a museum, but doesn't really change the society. So since November 2023, unfortunately, I think for many of us, the world has not necessarily gone in the direction we would have wished. But that doesn't mean that that there have been a lot of interesting things and positive developments also in different contexts. So what we are hoping that in these turbulent times, that we can come together and find opportunities to transform, because we also think that when shocks occur, it's also an opportunity to transform the system as a whole and to re-question the whole thing. So today we want to shift this focus from declarations to implementation, and especially bring, as my colleagues were already mentioning, the role of civil society in pushing for accountability, protecting rights, and embedding gender equity and human rights in universal health coverage. We hope to leave this session with kind of clearer ideas around 3 questions, and I will read them to you so you can also think about it, because as mentioned, this shouldn't be a one-way session, but we hope you will be interacting and sharing your thoughts. We will have a session for kind of more interactive part towards the end after the first questions. So first, how can gender and rights be safeguarded? And not only safeguarded, also advanced in universal health coverage and health systems? What are successful examples and lessons learned from different contexts in operationalizing what we call kind of our recommendations to integrate gender in universal health coverage? And very importantly, on this fellowship part, how can civil society, governments, and partners work more effectively together to uphold gender equity, human rights, and health equity in universal health? So with that introduction, let's begin by grounding us into context and getting to know better our panelists. So I would just ask each of you, maybe we can start with you, Alini, to just introduce yourself, tell us a little bit about you, and also why is gender equity and human rights in universal health coverage matter to you personally?
Hello. Thank you, Carmen. Thank you, WGH Switzerland, for the invitation. It's an honor to be here speaking on behalf of Women Global Health Brazil. So my name is Aline. I am from Brazil, and I have a bachelor in international relations. I am a specialist in public health and health management. I have worked in the government for 6 years. I worked in the State Department of Health of Maranhão, which is a state on northeast of Brazil. I don't come from Maranhão. I actually come from the very south of Brazil, Rio Grande do Sul. You can check on a map later. It's very far. But now I'm working in philanthropy. I work in a Grant Maker Philanthropy Association from Brazil. And the importance to me is that gender and UHC, it's like it sets the bar. We only have fair access and effective public policies if gender is included in these discussions. It's very important that gender and democracy and universal systems are in the same page. Thank you.
Thanks so much, Aline. Maybe Elvis, we can continue with you.
Thanks a lot as well for the invitation. I think it's a timely moment for us to discuss some of these issues. Very privileged to be among women in global health and experts as well. I kind of usually find myself in such situations, so hopefully I will not disappoint. My name is Elvis Safari. I'm originally from Kenya. Currently work with FIND as the acting head of Women's Health Program. And I'm a public health expert with background in nursing and midwifery, as well as a doctorate in public health and epidemiology. So yeah, that's a very heavy question. And for FIND, basically, our focus mostly, or rather the focus for the Women's Health Program is mostly to expand diagnostics for women in low and middle income countries. That's mostly our focus. And we mostly do this working with countries, developers. We also work with healthcare professionals, communities, just to make sure that we spur diagnostics as part of the integral resilient health system. And just interesting, the other day I read a report that between 2013 and 2023, Africa received about more than 100 billion through health aid. And yet less than 10% of that was actually directed towards women-specific conditions like the maternal and reproductive. That already is an issue. It means there's already a devastating gap that we need to discuss. There's already an elephant in the room that we need to share and see how we sort it out. At FIND, we have different programs targeting different conditions: TB, malaria, antimicrobials, NTDs, and even NCDs, which are currently on the rise. Women's health program is the only program that focuses on women. Why? Because of two key things. We have conditions that are unique to women. At the same time, we have conditions that disproportionately affect women. So it means there's a multifaceted and complex conditions that if we decided to just focus on one condition, then I think that will be unjust. So back again to the question, why advancing gender equity? Why human rights? And I think I'll state the obvious, because I think the obvious still needs to be mentioned at such platforms. Many women in low and middle income countries face delays in diagnosis. There are even missed opportunities. Certain situations, they're even denied care. Why? It's not because of lack of tools or diagnosis. It's because these tools or the system has not taken care of women needs. It's always a top-down approach. We are not looking at things from the ground going up. Yet here, you asked, why advancing gender equity? Why human rights? Because of such reasons. If we are not looking at, or if we are not addressing UHC, then I don't think it is complete. And if we don't involve women in such discussions, then it's just unjust. Maybe I'll just stop there for now.
Thank you so much, Elvis. Ania Maria, maybe you can tell us about yourself.
Yeah, my name is Anja Maria Rittner. I'm the odd one in this round. I have the feeling I'm coming from Association of German Health Insurances, but I have been Geneva-based until last summer, working in the field of global health with the Konrad Adenauer Foundation. So I've seen both the global and the national perspective, and also very much appreciate the time I had here at experiencing the multilateral feeling in this. And obviously, going back to Germany, that showed me much more. Well, obviously, Germany in multilateral discussions always is a champion for health equity, for gender equity, for advancing women's rights, for gender. We're a strong advocate, not only in universal health coverage, but also in general. We have the feminist foreign policy, we have feminist development policy, we have feminist global health, we are advancing sexual and reproductive rights. And then domestically, I mean, you were talking about low and middle income countries, but domestically, I find the picture also much more fragmented. So it is not that we have done our homework and there we are pushing it into the world, but I have really the impression that we have to align our domestic activities with the international commitment that we are presenting here. So let me get into two little aspects on where we find this disconnect. One is the perception of women's health as a deficit. That's still very prevalent, and everything we see when we talk about women's health, it's always, well, we have to see for the untypical, the lags that are in there to balance gender in there. And I think we have to reframe this whole discussion to get a gender sensitive approach, which can equally be good for men and women, obviously. if we look at, for example, men's mental health problems or breast cancer in men, so it's also the men that can profit from a gender sensitive approach, because we see in our data that the care quality also lacks in special conditions with men because of the symptom profiles not being gender sensitive. So this is really important to have the gender lens on for all of us. And then from the perspective of the one who's paying it, the insurance, it is obviously also important that we quickly get to the diagnosis. And this is not the case so far because we have long diagnostic pathways and therefore also costs. But there's hope. There's hope also for German healthcare system. As an association, we support projects, and I want to highlight one which it's especially important to me, being responsible for prevention aspects and rehabilitation. So we have one project which is called Heart Gap, and it's financed through the Innovation Fund in Germany, which identifies gender-based disparities in inpatient cardiology, and crucially develops then practical implementation strategies to close the gaps, to also close the gaps in medical training, because still today in Germany, gender doesn't play a cross-cutting role in doctors' training. Yeah, I'll stop there from that, but yeah, my plea would be we have to do our homework also in the high-income countries, in Germany especially.
Thanks so much, Ana Maria. And as you can see, this will be a very rich discussion. Last but definitely not least, Flata.
Hi, everyone. Such an honor to be with you. My name is Flata Mwale. I am from Women in Global Health Zambia, a biomedical scientist by profession. So I'm excited to hear Find is here. I'm a global health specialist, more so in implementation science, and currently also channeling into infectious disease control with a focus on climate change. I come from Zambia, and I have been working a lot in HIV/AIDS programs, particularly the last 4 years I spent delivering services in peri-urbans, in the rural parts of Zambia, which is more northern. And I saw firsthand how women and men in those settings are struggling to not only have access, but to utilize the services even when they're available. So why do I think UHC requires gender and human rights approach? Because I think we have an opportunity to allow everybody to exercise and have a supportive environment in which they can experience quality life. And it is only through UHC that we can optimize and ensure, irregardless of your gender identity, your social background, your geographical location, or even what you do, you have an opportunity to experience good health. And I think that is what I would say for now. Like, it's really important that we advance it. Yeah, thank you.
Thanks so much, Flata. And also thank you, because I think kind of with each one of you, we've been also expanding our understanding of what do we mean by universal health coverage? And it's not only about providing services, it's not only about understanding the diagnostic aspect, about the policies, but it's about having this supportive environment so everyone can thrive. So maybe Flata, as we finished with you, we can go back to you. And you were talking a bit about your experience in Zambia, kind of through your journey, but maybe also within Women in Global Health Zambia. What have you seen? So since the political declaration, I mean, if we look back now these last 2 years on universal health coverage, there's kind of this renewed vow for this is important. Governments are saying yes. But where does gender and human rights kind of stay, kind of this concept of leaving no one behind? Where does it stand in Zambia? What has happened in these last 2 years? What do you think have been maybe the biggest achievements, but also the biggest implementation gaps?
Okay, so from the Zambian side, I love that you mentioned leave no one behind. It's a very strong theme in our national strategic plan, and we sing it as a nation. And I would say that as a country, I think there's a lot of push to really incorporate gender within our policies. We're moving towards gender mainstreaming, and that's evident because we have seen over the last 2 years, each provincial office has been allocated a gender specialist that is working with different departments and sectors to be able to ensure that there's the gender responsiveness across different programs. Within the National Health Strategic Plan, gender inclusivity is sort of implied through the equity principle, where everybody has access regardless of their gender or where they come from. More specifically, we do not have specific aspects coming out within the current strategic plan that we're using. However, the implementation of programs has been a little bit much more gender responsive. For example, maternal health and adolescent health, we've seen much more push in trying to improve the livelihoods of pregnant women and children, more so also adolescent girls, especially in access to sexual reproductive health services. That's been a very good drive. Another interesting one has been the area of HIV/AIDS. I think that's where we've seen even the more diverse approach towards gender. I come from a country where certain identities are not recognized, but when it comes to HIV, we are not denied to give services to anybody. And I think that's been very, very good. It's worked very well for us, and I hope that we can sustain it. A very good example, again, I can cite is the male clinics. There's been a lot of scaling up and expansion of men's clinics. And I think my colleague spoke about men's mental health. But I think particularly for my setting, it's this fragmentation of gendered services that made the health facilities look very feminine. And so men did not have a space within which they can seek healthcare, particularly for those in the rural areas who are self-employed. They do not have formal ways to get leave days. So coming to a very feminine health setting would take away too much time. And they decided, they would often decide not to seek care. But with the implementation of the men's clinic, we've seen much more uptake of services. And there's sort of an environment that they create friendships. And that's what we're talking about, creating an environment where people are empowered to own their own health and support each other. And I think that's another area where we're doing well, and I hope we can expand that. But I should also mention that as Women in Global Health Zambia, post Women Deliver 2023, we went back to the drawing board, looked at the National Health Strategic Plan, and we say this does not reflect the needs of different diverse people. And there was an inception meeting that was held with stakeholders just to discuss how a gender strategy would look like. And it brought together local organizations, of course, international representatives. But again, politics come into play. We changed the minister. We now have a different one and sort of died out. But we're hoping that we can really pick that up, because what we currently see is all-in gender policy, where everything is being tried to be put in one gender policy under the division of gender, which falls under the office of the president. But I think it would be much more beneficial if we had gender in all policies, and not just implied because there's a wording there, but to have more practical approaches that will literally link the social determinants of health also to addressing the overall health dynamics and how they play out within the gender space. Yeah, thank you.
Thanks so much, Flata. And also thank you for bringing so many also specific examples of how Zambia is doing things that maybe can be interesting for others and lessons we can extract from it, but also how Women in Global Health Zambia is trying to push for this gender in all policies. I think that's definitely something that we will be picking up later. Maybe Elvis, let's go back to you, because you've also kind of had quite a transition, as you were telling us before. So if we look at, as Flata was pointing out, lessons learned, but also what have been some of these challenges in bringing gender human rights approaches to universal health coverage. I think often we hear about these concepts, in a classroom. I was just giving class yesterday, and people are like, yeah, this is great in a meeting room, but then in the practice, it's much messier and those concepts may not translate into reality. So as you have kind of had a whole journey, what do you think are the most significant challenges to integrate, as Flata was saying, this gender in all health policies or in all policies when we talk about universal health coverage?
Thank you. I think for me, there's need to step back first and kind of ask ourselves. We are talking about universal health coverage, but it's universal for who?
Mm-hmm.
I think that's the biggest question we need to ask ourselves, because many a times we just like what Flata mentioned, we use the word universal in our systems, but it's not really designed to sort of help women navigate the health system. So that's the biggest issue, even before we move into challenges. And I've been fortunate enough to work in even harsh areas as a nurse, both rural, peri-urban, urban, humanitarian settings. And I think just like her, I've witnessed firsthand experience, particularly for women, when the only thing that they have to do is sort of hope. They have to hope or even just survive. Or even worse, just sort of see if they live to see another day. And we should not be living like that. There are also other issues of gender inequities, system bias, and even out of control measures where you see there's a lot of silence from women, because just like my colleagues say, they're not involved in a lot of these things. So they keep quiet, and this costs a lot of life. The structural inequities is not only in care, we also see it in innovation. Just the other day, the Impact Global Health latest report on women and R&D research, there was something really significant that I read. It was really striking that most women in health condition funding is only for basic research. Only for basic research. And that means also that very little investment goes into getting the product to the patient. So it means all these discussions are only at conceptualization stage. We don't think of sort of having this technology at the hands of women. So that in itself is an issue. Back again to the question, I think the biggest challenge, and I think Sarah alluded very nicely into this, is lack of political will and involvement of women into this engagement so that we see how we can change the system. And I'll break it down into three challenges. The first one is invisible data. We talk a lot about data. There's limited data that usually generated, for example, sex and age disaggregated data. And because there's limited data for women, then decisions cannot be made because there's no data. And a lot of funders in our setting right now, it's easier for us as we write proposals to convince them with numbers. We've done X, Y. This is the outcome. We need a little more funding to reach a certain level. But when it comes to women health research, we don't have that data. So how do we convince them? We've not been generating this data so that we can be able to tell a story and see how far we are moving. So that's the first one. The second one, and I think this is one of the biggest, is design disconnect. I think a lot of health interventions have been built around male norms, urban clinics, ideal conditions. But like I mentioned when I was starting, women's health is complex. It is chronic, and there are various and many stages, as we call them, life stages in development. So if we have not taken into account, to design products or health interventions around women. We do it for them. And then we end up not getting the right technology, innovation, health interventions that specifically address the needs of women. And lastly, the third one is delivery gaps at primary healthcare level. There's a lot of discussions about PHC. Why? Because this is the first point of entry for women. Even in all my experience working, that is the first area where they come into contact with the primary healthcare level. But then the PHC levels are not ideal to sort of even initiate the basic care that is required for women. And many of them, unfortunately, are just being used as a referral route. So you start there and immediately there's nothing we can do. Please move on to higher level of care. And there is a lot of complexity between the PHC and the next level of care that we could talk here the whole day. So I think it's time for us to sort of flip this model and sort of ask women, talk to them, listen deeply, design with them, and most importantly, deliver with dignity. Thank you.
Thanks so much, Elvis, for such a well-structured and holistic understanding of, kind of in 4 minutes you packed in so much information. So good luck to us to digest this all. I think it's going to be I'm very excited. Maybe Ania Maria, you were already pointing out this before in kind of Germany's dual role as a donor, but then also the differences between what you preach with what Germany as a health system actually does. Maybe you can expand a bit on those disconnects, and you were already explaining a bit also some projects. Maybe you can build on that and tell us why, and maybe also kind of why is that such a disconnect? Maybe it's easier to say things than actually doing. Yes.
It certainly is, yeah. Why is there such a big disconnect? Well, I mean, we have a new government coming in now. They have been in office for 3 weeks, not even. And if you look at what's the claims in their coalition agreement, it's 144 pages long, and gender really plays a minor role in there. Gender and women's health appear marginally. So gender has really been moved away from the agenda, by other geopolitical important challenges. And whereas we find that might be interesting for you, encouraging signals concerning violence against women, which is well anchored in there, and we see that at least half of the ministers in the new German government, or almost half, are female. We still see that women's health in there is only looked at, as I said, from a deficit-oriented lens. We have endometriosis being mentioned there. We have menopause mentioned there, and that's it. That's it. So it is really to overcome this disconnect. I feel that it is also our job, like as part, like the insurance companies, also all the partners we are partnering with, the associations of medical organizations, to really advance this despite of the priorities which have been shifting.
Thanks so much, Ania Maria, and I'm also happy because you're already we have contextualized why this is a thing that we need to continue discussing and acting upon. Universal for who, and this universal for who, I think, speaks very much on the experience also from Brazil. So Aline, I think, well, I'm also doing my PhD in Brazil, so that's why I kind of know a bit about the health system, and I've actually, I've learned also concepts in theory around intersectionality, leave no one behind. But it's been for me going to Brazil a bit of seeing what that actually means I don't know if in practice, but at least on the policy and living this, because the inclusion and centering of people from different backgrounds, and when we talk about the leaving no one behind that Vlada was saying is the song in Zambia, it's not only about applying a gender lens, it's also about thinking about indigenous groups, Afro-descendant groups, it's thinking ethnicities. And that's kind of also what we mean when we talk about intersectional approaches. So maybe you can tell us a little bit of how has Brazil integrated or tried to translate this universal health coverage with those principles into a reality.
All right. The intersectionality is the base of Brazil health system. Actually, we actually have a universal health system that we call SUS. It's a unified health system in English. And we don't actually use the universal health coverage because of our health system. The coverage is actually more an indicator if this health system is reaching the population. And our health system has a great story, and our health system has roots in our dictatorship period back in the 70s, and there was many social movements back then claiming for democracy, and our sanitary reform movement was one of them. And it's a movement that made such difference in Brazil history and managed to put health in our constitution. It says that health is a right and a duty of the state. So the state must provide health services and access. And this system is also based in some principles, which are universality of the access, equity. It's on the base of this access, and it guides the politics from specific groups such as women. Social participation, it's also one of the main principles. We have social mechanisms that society plays a very important role in decision-making progress together with the departments of health from the states and from the national government as well. And so, as a society, we understand ourselves as a mixed country, mixed population. We show mixed with diversity. So this health movement was so important that in Brazil we have a health field that's called literally collective health, which focuses the health thinking in Brazil in the individual, in the social determinants of health, in the collective, thinking about people. So from the beginning, the health in Brazil is very connected to democracy, to equity, to paying attention in the all diversity of indigenous, the African descendant people, LGBT community. So when we talk about health, there is always this strong and resilient movement that won't let these principles and all the conquerors that we have in health now to just fade away for political will. That's it.
Thank you so much, Aline, because I think, and maybe as you were finishing with the social movements, and this is again what we want to bring and invite all of you to see which role can we play in pushing for this agenda and universal health coverage. Clearly, in Brazil, it's played a huge role historically, but we don't have to go back to the military dictatorship, right? I think we've all been familiar with the government of Bolsonaro that was in place in Brazil for 4 years. Maybe you can tell us a bit what were lessons learned during that period, also in your own experience of how can we safeguard gender equity, human rights in moments of political hostility. And I think all of you have been mentioning politics, political will. So yeah, what can we learn from you guys?
Well, like continuing my speech, I think one of the lessons is to have institutionalized the social participation was the make the great difference because there was this historical participation in health politics, and then when we were like in the moment that these rights was under attack, the society also responded to it. So it is very important that we have the movements already organized and aware of the history, where they came from and where they are risking to lose. So although in the recent years many councils have shut down in the national level, the national government shut down a few councils that are from people with disabilities, LGBT, and other councils were shut down in health. Everything kept going in a certain way. Because of SUS, because of the laws, because of the constitution and the history. So one of those mechanisms are our health councils. They are present in municipal, state, and national levels. These councils are part of the decision-making process. They take the demands for the State Department. They monitor the politics, and there is something, also the resource allocation. They are part of all this process, and then also every 4 years there are conferences actually in the municipal and the state and the national level. So when we have elections, someone wins the election, it needs to prepare the politics for the next 4 years. So there are these conferences in every city, in all the states, in the national level, together the demands from the society and the proposal for the next years. And there are also some conferences that are organized by these governments, and there are conferences just like the side events that are organized by social organizations that gather all the demands from specific groups and somehow manages to put it in the main conferences. So just similar what we're doing here today. So yeah, that's we learn how to be resilient in difficult times, and that civil society must not be never be disorganized. We must be aware all the times because of political wills. Although there are many laws and institutionalized, we need always to be aware of what's coming.
Thanks so much, Aline. So Elvis, we look at you now, and I mean, we're now talking about lessons learned, and obviously each of you has different lessons from the role civil society can play and how we advocate for gender equity in different fields. So what are some lessons learned on how we operationalize this lens into universal health coverage, and maybe also some examples you were already pointing out from FIND on the women's health program, but then also how do we mainstream this beyond?
Yeah, I think I'm more concerned with the way things are moving, because countries are usually very fast to update policies, guidelines, just to make sure that there are certain keywords, buzzwords that sort of reflect that. So gender equity, gender balance. So when you look at certain policies and guidelines, they're really up to date, the wordings is there, but the practice is not there. I think that's where we need to address the issue. And I think for us at FIND, practice begins with active listening to the women, listening to them, trying to understand their needs and their concerns. And I'll use an example of a current ongoing project that we are doing in Kenya in collaboration with a civil society organization. We are doing structured listening exercises where we are asking women, what do they really want? How do they define their health and well-being? What is really important for them? How do they maintain their health? And you'll be surprised, you'll get even questions outside the health domain. Some women will just tell you that for us, I just need safe water. I need food, because some of these concerns are the ones that are driving them to go to the hospitals. And so we've done this across several counties in Kenya. Kenya has 47 counties. We've done this in more than 30 counties. So it's quite a strong representative. We have more than 50,000 responses of women. So there's tons and tons of data that we are still trying to sift through. And basically what we want to do is to ensure that women's lived experience is actually considered during the design, product phase, and even preference in terms of their care. And we are using sort of an approach where we act, we listen, and then we ask, listen, and act. So we've already asked the questions, we've understood their needs, what they want, what's really happening. So this is sort of the phase where we generate all the evidence. Now we are currently in the listening bit. So in the listening bit, we have sort of a twist. So we've already asked the women the questions. And now we are going back to the county officials, the Ministry of Health. We've mobilized several stakeholders in these different counties just to tell them the feedback that we've got. And then also another activity that is yet to start, we will sort of look at what women are saying vis-a-vis what is provided in the health facility and sort of try to identify where are these gaps, because definitely there is a problem. Also looking at sort of policies like the EDLs to sort of try to understand, are these concerns sort of coming from a diagnostic lens? Are the tools missing at the healthcare facility? But yet again, the policies are very up to date. The EDL list is up to date, but when you go to the primary healthcare level, tools are not there. So that is sort of the exercise we are currently doing. And I think the ACT bit will be the most difficult for us, because here is where, and I had someone mentioning commitments. Here, basically what we'll be doing is making sure that governments and other stakeholders commit to what they will do. We do not want to sort of have a project where at the end of the day, we have tons of data, but policy or implementation or change is not happening. And we're already receiving some sort of commitments and changes in certain counties. We are getting varying concerns in different counties, depending on the women needs. And we are using this to discuss with different stakeholders. And I can give an example. In one of the counties, I think the biggest issue was water. And with water, we know there are a lot of waterborne diseases that sort of drive them to go to seek care. So we are looking for partners who would help us sort of address this and not just, sort this as part of the priority. No, we are looking at it from the women's perspective. This is their priority. This is their need. What can you do to sort that? So like I mentioned, I think the ACT bit will be the most difficult one, where commitments are actually enforced. And we want to see this through even beyond the project, that we follow up with the partner in Kenya and make sure that sort of this is addressed. So basically our lesson here is using this model to make sure that women become co-creators in addressing their own concerns rather than pushing the narrative to them. Like I mentioned, we've had a history where things are, there's a top-down approach. I think what we are trying to do is a bottom-up approach where we first look at the women, we understand their needs, and then from there we move upwards, pushing the concerns and preferences as we see how we change, policies and how we could address the various needs that we find along the way. Thank you.
Thank you so much, Elvis. And I think we're nicely building kind of the role of different partners and lessons from kind of how do we institutionalize social participation, the importance of organized, but also kind of partners like FIND in rethinking how we approach universal healthcare, equity, gender. Flata, what are from also the Women in Global Health Zambian chapters, some lessons on how you're doing and pushing for these topics in practice, and kind of lessons we can learn, but then also challenges that you want to raise?
Yep, thank you so much. So from Women in Global Health Zambia, actually what we have learned, my colleague spoke about data. It looks so good when people have gender disaggregated data. 96% coverage among girls, and but when you get down to look at the numbers and what they mean, we cannot tell the impact of those numbers in the lives of women and girls. And so we have taken a step, also acknowledging that we need gender included across all the building blocks of the health system. As Women in Global Health Zambia, our first step was to bring to light that gender inequity is actually so strong within the health workforce. We did a study on workplace violence among frontline immunization health workers, which concluded earlier this year with the support of CDC Atlanta. And what we found is that a lot of community health workers who are unpaid and underpaid are the ones who are going through a lot of violence. They are, as they go to deliver services, they're being exploited, they're being harassed, but nobody's talking about it. And these are the women we're putting in front to ensure that service delivery is happening, because they are the face between the healthcare system and the community. And so we have taken an approach to bring in evidence-based advocacy. We're saying, look, this is what we're finding. And when we say, can we have gender included in a policy? It's not because women are making noise and you will shut them up by putting a word in a policy document. No, it's because these are lived experiences. People have real lives going on, and this is what is happening. So that is what we are trying to build and we are calling for. So we do know, yes, there are problems. We do know, yes, women are affected, but can we do something about it? Can we begin to design and like my colleague said, co-create solutions with the women? For example, within the health sector, in my setting, I am more useful seeking services when I'm pregnant or breastfeeding. Any other time, I don't, my needs are never met. And nobody asks me what I need outside this reproductive age. Mm-hmm. And we see that with the life expectancy increasing, more women are going to experience menopause. And my mom is an example. I literally have to become her personal doctor because she has had to juggle her whole life, how to figure out the changes and everything. So there's so much that we need to do. But again, gender, data-based advocacy, evidence-based advocacy is required, and we are pushing to do as much as we can to bring out the evidence to support that. But also there's a lapse between what's in policy and what the program implementers are doing on the ground, or how they understand it. I have been in program implementation for some time, and I would tell you most of these things, I would know them because I'm sitting at a certain level in meetings. But the people that are actually delivering services at primary healthcare do not even understand why we need gender in these policies, or what gendered strategies we could develop for them to inform the bottom up sort of approach. So we need to raise these conversations, and particularly among healthcare workers, and begin to have conversations, and it just doesn't remain among the top people who understand it, but get it to the ground so that people begin to drive it, not just in the health sector, but because they're also living within communities, right? And they have these connections with the people within them. For me, health is a very neutral right, and everybody connects to it in a way. It doesn't matter who you are. When your health is threatened, you do something about it. And so we can use the health sector to be able to directly connect the other challenges that women are facing, as he spoke to the water challenges. There's also social determinants that are driving all these aspects around women's health, and we need to push for that. And we can use health to be the source of the strength that we need to ensure we address the challenges. Accountability zero. There's very little accountability. Just recently in Zambia, well, the government together with its partners, the Germany and the EU, they went through a review of the policies just to see how the gender impact analysis is happening. And there was nothing. Gender is there, like my colleague said. It looks good on paper, but there's no impact analysis. So the current government brought in financial economic empowerment programs. There's no gender responsiveness. We don't even know who's getting that money. But everybody, when you look at the document, it looks there. So we need to step up as civil society organizations to be able to hold governments to account and ensure that they deliver on their commitment to the people. And of course, enhance the success stories. What we've heard from Kenya is something we can learn from and say, okay, how do we learn on listening from the women so that they tell us what they would like and how they would want it to be delivered? Because ultimately, if we don't listen to them, they are the ones who we will have services they will not use because they don't need them. Yeah. Thank you.
Thank you so much, Flata. Ania Maria, I think we've been hearing of the role of civil society with kind of partnering with different actors. You have also kind of had your own journey, as you were saying. Maybe you can tell us also from the lessons learned, and we already combine it with the last question, just so we make sure we have time for engagement in terms of what are lessons learned and how this collaboration can look like. And if we look ahead, how can we build stronger, more unconventional alliances so that we can challenge also these entrenched power dynamics?
Yeah, I would actually pick up on the points you were bringing in, the ask, listen, and act. This is something which we very much and explicitly practice in all the prevention activities we are developing. We have now differentiated different movement classes in our prevention field by gender, and we see, especially for the ones targeting women, that those are much more sustainable if we close the group to women only. And from the health co-insurance side point of view, this is so good news for us because they really stay in these groups even after the funding ends. So they continue to do that in the local structures, in those associations or with the fitness hubs they're into. So I would really emphasize this was built on a study we had before where we really looked at the needs. So the ask, listen, and then act is something which works all over, not only in low and middle income countries, but also here. And the other one, so that this is kind of the bottom up view. If you look at it from more top down, we already also mentioned the point that we need gender in all policies. So I think really to break those power dynamics, we have to go beyond the health sector and see gender as an alliance across the systems, be it education, be it labor, digital inclusion, environmental justice. I mean, this is all coming together there. So health equity doesn't exist in isolation. And the advantage we have in the German system, still going back to Otto von Bismarck in 1883, when we installed the statutory health insurances, already at that point, it was also the responsibility of the employers to care for the health of their workers and to get engaged and see the economic value of health, and then nowadays I would say also of health in different populations. So, for example, on our boards we have representatives from employers and from insured people, and so this is a nice institutionalized way to get the people concerned into the decision making, and yeah, I think that works quite well, although I know it's maybe hard to build up, but this is a good sign for stability in the German system.
Thank you Thank you so much. Could I ask maybe each one of you to give those short reflections when we look ahead? How do we build, how do we continue, maybe picking up on Ania Maria, who brought the more health insurance specific model, this type of alliances so that social participation is institutionalized, that we continue doing bottom-up approaches despite what may look as moments where everything is falling apart, and how can we use these rooms to organize? Who wants? Maybe Aline.
Open mic. So, I was going to say, these spaces of social participation are very important. But God, I forgot what I was going to say. Sorry. I mean that. Okay. The government is knows that they can do everything by themselves. So social participation is it's part of it, but I think it must be. It must get bigger. You know, we need to have spaces where philanthropy is together, the private sector is together talking, everybody's talking together. And an example of this, and one of the challenges of SUS is the digital health. And one of the main difficulties of SUS and the other health systems and coverages are the financing. So digital health requires a lot of financing for hardware and softwares and development and training. And the Ministry of Health in Brazil doesn't have all it takes to provide a digital health for the whole country. And Brazil, it's a huge country with different struggles in every region and a great population. So, and we have the ministry launched in 2020 the strategy for digital health for 8 years, so the 2020 until 2028. And it acknowledges the need to put more people to be talking together. So more people to think how this digital health would help improve the system and not to maintain inequalities, because when it's talk how we gather data, how do we process data. And in Brazil, it's a challenge. We do it mostly in paper, and then some of the unities of health put in the system, and not all data is collected. We lack many racial data. And for an example, in 2020, I was in the committee crisis for COVID-19, and we were gathering the data from the COVID tests that the population was taking. And we would receive just the name and the city and the result of the test. And where is the data? How can I organize this by sex, by race? So we were implying some data because we needed to do a report every day for our governor. And we were researching people on the internet so we can try to put something there. And that's part of the improving our process that we have to do.
Thank you, Melvi. Elvis?
Yeah, I think we need to be very intentional and sort of bring people who need or ought to have been brought in the same room, but that didn't happen. For example, having frontline nurses and midwives together with designers. Because many times there's a lot of assumptions, and because they've not been working together, which ideally they should, then that is not happening. And we end up with, as an example, technologies that don't really address the needs at the community or the primary healthcare level. Another example is sort of having grassroots movements or organizations with regulatory authorities or the regulators. So these are just examples where we need to build coalitions where we sort of pull relevant stakeholders together, including women, not as beneficiaries, but as part of building the solution. Where do we see opportunities? Just quickly. At the local level, I think I've already alluded a lot about primary healthcare level. I think that's an area where there's still a lot of opportunities, not just because it's being used, you know, as a referral route, but I think we can visit sort of the PHC packages. You know, that's another word that you get a lot in writings, but ideally when women go to seek care, there are so many things that are lacking, including medication, and they're told there is a nearby private health facility where you can go and seek care, but their coverage does not take care of that. So you have a cover that does not cover. So what's really the need of that? At regional level, I think we should take advantage of bodies like, you know, the African CDC and other regional bodies to see how we sort of drive our agenda. And we are just having a chat outside, sort of forming regional alliances that have strong movement and forces to sort of at least you have an opportunity to be listened at, because now there are usually so many high tables, and if you don't have that then you don't get listened to. And I think at international level, or global, I love what she said. We are seeing that a lot of conditions are only, or a lot of funding is only covering sexual and reproductive age. Anything outside that is not taken care of. And I think she had a very good example of a mom. Now she is a personal doctor, but we're also seeing that in diagnostics. A good example is female genital schistosomiasis, endometriosis. When you talk about breast cancers at primary healthcare level, there is no capacity to do anything. Why? Because a lot of funding only focuses on the sexual and reproductive health. Even through our listening exercises, we have people who are outside the reproductive health. They are complaining that every time they go to seek care, even the nurses and the doctors don't know how to help them. Why? Because they don't know, I mean, they're not in that age group where they can be helped. So where do they seek care? They are not being included in the narrative. And I'll stop there for now. It's getting too emotional.
Thank you, Flata. Where do you think, where do we go from here before we open to everyone to give us their ideas?
Yeah. So what I have learned over a few months is that policies, no matter how good and inclusive, they are like promises. They can be broken and changed, and then that leaves civil society organizations, especially those that are championing for gender equity, with the responsibility to be able to stand up and hold the line, because we need to be accountable to ourselves, but also to the people that are looking up to us. So in my view, I would say we need to collaborate more. Civil society organizations need to collaborate more. We need to integrate our activities. We need to pool whatever data, whatever evidence we have together. And when we approach a table, if it's a one-time chance, we go with a one-time chance and deliver everything at once. I think sometimes we do have moments, for example, in my country when we come together, but it will usually be due to an event like the 16 days of GBV. But also it's been exciting for women in Global Health Zambia, because over the last few years, we've seen an increase in the number of female CEOs who are running financial institutions. So we are able to go to financial institutions and ask for support right? We need to innovate around financing this civil society work that we're talking about. So it's much easier when you explain the challenges that women are facing to female-led organizations and they're willing to jump on board. So I think we also need to keep that on the agenda. We need more equal representation, and women must be on the decision-making table, because it also speaks to a lot of other things. Yeah.
Thank you all, and we are obviously tight on time, but I would still like to have the opportunity to open up to you that have been so far passively listening. Anna has the microphone. Maybe we can take up some comments, thoughts. So where do you see the role of civil society stepping up to safeguard gender equity, human rights in UHC, or any questions that you have towards the panelists? There's 2 hands in the back.
Thank you very much. Yeah, my name is Amit. I'm originally from Nepal, and I work in the intersection of politics, so with political actors on health, as well as technically. And I'm also a PhD student at the same institute as Carmen. So my question is actually partially already addressed by many of you, and it has to do with this global movements of universal health coverage, which is, you know, part of SDGs, and many governments have signed and so on, and created policies that many of you have said is maybe going unimplemented, and the local movements, local political movements that exist in these countries. And maybe ones where you haven't addressed it directly, but like how do we bring these two movements together? Because what I see is that democracy, institutions that respond to people are critical and important for healthcare delivery, but not just for healthcare, but everything else. Sorry. So like, yeah, how do we bring these two movements together?
Maybe we take the other question first. It was in the back.
Hey, thank you for the incredible panel. My name is Molly. I work for a project called the Digital Health and Rights Project, and I was really interested in the kind of comments on digital health and the potential that has to further gender equity. But just wanted to raise some points from a research report that we've just launched last week, specifically thinking about gender and digital and the challenges that women and girls are facing around the world. So, for instance, we found that women in all of our study countries have significantly less access to the technologies and data and internet connection, but also lack digital literacy skills and are underinvested in when it comes to being empowered to use technologies. At the same time, community healthcare workers are often women and being asked to deploy new technologies all the time to kind of improve universal health coverage, cost efficiencies, etc. So yeah, just wondered if you had any response to balancing the positives and the potential of digital technologies, as well as those kind of specific intersectional gender challenges that we're seeing on the ground. Thank you.
Thank you very much. Just looking at the time, I would say we give 2 quick responses on the digital health and question of global local movements. Who would like? Yes.
Thank you. I'm going to speak to how do we bring the movements together. I think what we've seen in the last month in my country, there was some sort of wave where there was a lot of reporting on child molestation. Like literally every week we had on the news a child less than 10 who was molested by a male guardian or a relative. And we saw how we mobilized together the human rights movement, we from the health sector and also the education sector as well. And we were able to come together advocate for more stringent policies that should protect children, right? So then it showed that we are able to bring ourselves together. But I think the problem is we are trying to treat each issue as a separate entity, and this is where we need to bridge the gap. We need to see health in social issues in health, human rights in health, democracy in health, health in democracy, and that way we'll be able to collaborate and integrate much more and be able to drive that forward. Yeah.
Thanks, Flata. And the digital health, I don't know, Elvis, as you were mentioning.
I think with the issue of gender, digital health, it's two sides. It's two sides of the coin. In one side, there are affordability issues, and here I'm speaking about low and middle income country. And on the other side, there are access issues. So basically, what we are also getting challenged, and this is also an example of a project that is currently ongoing in Vietnam and also in one of the states in India. So not just push innovation or sort of technology to women, but sort of have a time frame where there's capacity building also for healthcare workers. How the technology is being used, because like I mentioned, we are really advocating for technology that is being used at the primary healthcare level and even going further to the homes of these women. So a good example is the HPV DNA test for cervical cancer. These are simple to use tool that can be used at the comfort of their home, but many of them do not know how to use it. So we work with a lot of civil society organizations like Archer, who are very prominent in cervical cancer movement, to sort of design IEC materials that are being used now widely to help support women to understand what is cervical cancer, when is the best time to, sort of screen yourself, how do you do it? So with that, it helps people to sort of understand and also helps to bridge sort of some of the challenges that you just raised, both from the women perspective as well as the healthcare worker. But I know there are also other ways that it could also be addressed. This is not only the solution.
Mm-hmm.
It also depends on the kind of issues that we are getting in different settings. I don't know if you want to add something.
Thank you all. And I'm really sorry to cut this round short, but we have actually reached the end of our time. And I know there's another session coming up. So if it's okay for all of you, I would invite Andrea to wrap us up. And I would invite you all. I know there's a coffee machine just around the corner. And I really hope we can stay a few more minutes and continue these conversations afterwards. Thank you so much.
I'm not going to get in the way of coffee, but I want to just talk for just a quick moment about something that resonated for me. Hello, Alice. Which is about the pleasure of connection, right? This is a place where we're talking about urgency, where we're talking about health, we're talking about violence, we're talking about these things. But we're also talking about civil society in which every single one of us is engaged in civil society. And sometimes we're engaged in it because we're angry and there's things that have to be moved. And we absolutely, as someone was saying, we have to stay vigilant. In my home country in the United States, where abortion rights have been decimated in the course of the last few months, but also over coming years, vigilance is important. But fellowship is important. Community is important. Connection is important. The pleasure of the connection between us is important because it's the other motivating force besides the anger and the fear. So what I would like us to do here is to give another round of applause for the pleasure that you have provided us. Recognize that being in civil society actually meets a very fundamental human need that we have to be connected and to be moving things together. and to keep going and doing it. And we can start with coffee. We can move to on Thursday at 4 o'clock, 5 o'clock. I did it again. Thank you. Our meet and greet, and Anna, Pierre, and Megna. You can get any information. And thank you so much for your attention and for your expertise. I learned a great deal, which provides me also a sense of my own work in civil society. Keep going, keep being vigilant, keep finding each other. Thank you.